trying to have a lot of different things. We're going to have Bob Berger's going to start off with a update on I don't know what, something important having to do with electronic medical records or something.
Something like that.
And he's strictly limited till 12:30. Then he's out of here. And then we have three sort of pearls, kind of like a Pearl Day pearls, and each of them has 10 minutes, and that's it. And so we drag them off at 10 minutes. Whether they're finished with their slides or not. Sarah's looks benign, but she's going to be the one throttling them. So anyway, we'll go ahead and get started. I don't want to use up any more Bob's time.
That's fine.
Thank you very much.
Okay, this is going to be speed computing. I'm going to try to finish actually before 12:30 to allow for questions and comments, et cetera. As you know, eChart, which is the nursing application, it has been live on the medicine services for a couple months, so you no longer have door charts, and all of the residents and most of the attendings have seen this now, that you can access eChart through WebSys, and I'm going to show you that again. You can also access eChart from home now and from outside the institution, from anywhere in the world, through the WebSys link. For those of you who have IE7, and previously WebSys and eChart did not work, it now works in IE7. It's not supported, meaning that we are letting it work, but IE7 is inherently dangerous as far as its security holes. So for those of you who are thinking of upgrading to IE7, I wouldn't do it unless you already have a new machine that has Vista that has IE7 with it. Don't even try to take it off because it's impossible. It's very hard to do. But IE7, you're going to find a lot of packs that you're going to have to upload to get the security better, which is why we're saying we don't support it. However, it will work. WebSys will work with it, and eChart will work with it. So for the last at least a year, we've had a group of people, a lot of nursing staff, and then I'll show you the list of nurses and attending physicians who have worked to get the nursing documentation in the ICUs working. And that is scheduled to go live next week on Wednesday. So next Wednesday, there will no longer be a big white fold-out sheet, which has been there forever, okay, since I was a resident in the early 70s. So that sheet will go away and be replaced by what I'm going to show you, and I'll show you how to get to it. There's been a lot of people working on it. All the nurses in the ICUs have been trained. This is all the ICUs, the institution, are going up at the same time, not just medicine. So surgery and everybody except for peds, okay? So all the surgical ICUs will go up. So if you have a consult, you'll be able to find the previous flow sheet in this manner. Now, like everything we've done over the years, and I've stood up here and said this before, there's a trade-off on this. It's going to take you longer than just opening the white sheet and looking at the data, okay? There's nothing faster than looking at a hand-printed sheet, okay? The trade-off is the data is going to be accurate. It's going to come off of the monitors directly onto the electronic flow sheet. The nurse will look at that and validate it, so there will be a step where the nurse will validate it, but from the ventilators, from the monitors, and not right off the bat, but soon from the iMeds and from your infusion pumps, we'll directly bring that information over as well to electronic flow sheet. The flow sheet obviously has lots of, and the whole application of nursing has been left behind by what we've done over the last almost 20 years. WebSys has really been tailored for the doctors, so the nurses have really gotten short shift, and now they're getting their time. The nursing application is going to be very important because we'll be able to do things that are in the works, like a rounds report that will give you a quick snapshot of vital signs, and this is both on the floors and the ICUs. That'll happen hopefully in the next 6 months. Give you a quick snapshot to carry around of your patient's, last blood pressure, their last INO, their trends of blood pressure, weight, that kind of stuff. So there's a lot of good reasons to have the nursing application electronic. So I'm going to show you, basically just review this with you, so when you get to the unit or you're called to a consult, you know what to do. And this is the group, you can see that this is the group that worked on the physician view, and I'm going to show you that. We don't have time to show you how the nurses put the information in, but the nurses have undergone a lot of training on this. But you can see medicine had representation by Shannon. Where's my little pointer? So Shannon was on the group, and who am I missing? Yank was on the group, Eric Yang was on the group, and they're corresponding, and I don't count because I was chairing it, and I'm certainly not an ICU doc. And they're corresponding nursing coordinators within the units. So this was the group that designed over 5 weeks what the view would look like of this nursing documentation. So here's what it looks like, and here's how you get to it. So if you're I'm in our training side, so it's going to be a little slower. So you're in a patient. This, by the way, is version 2.7 of WebSys. So it looks a little different. You see a little charity care thing. You're going to see a lot of different icons in the new version of WebSys that indicate status of patients. But that's another discussion, and you'll be getting a memo from me in about a month when that version comes out. But like all of the rest of eChart, to get to the eChart record on this patient who's in the unit, you hit eChart link, and automatically you're logged in to the nursing application. And what comes up first is the usual view that you see on the floors now, which are the sort of the bare bones vital signs that have been put in, and any documentation that has been done by the nurse. So an admission note or any nursing note you get down at the bottom of that screen. But those of you who've been on the floors have been dealing with this for a while. To get to the ICU flow sheets, you come up to the far left, top left, and it's this third icon over. I don't know what, actually, I can't see really what the icon is. It looks like somebody with a paddle or something, but it's the third one over, and you click it, and you see the first thing says Clinician Flow Sheet. And then you click that. And this opens to the ICU flow sheet. And I'm going to go back a day because we have more data for the day before. And this is fake data that we put in, but this is its organization. You have your weights, and you have then your vitals and hemodynamics, and any lines that have been put in, like a swan, for example. Here's a PA diastolic, here's a PA systolic. So any of the lines that are taking measurements that are coming off the machines, this would go for aortic assist devices, et cetera, are coming right to this flow sheet. And again, as I said, we could just leave it alone, let this feed every hour and not have the nurses validate it, but we want the nurses to look at it, make sure there's not a spurious reading like leads have come off or something's happened to the swan, and then you get a zero number, which gets you all excited. So you'll see that first. The day is now different. It's no longer shifts. Our existing white sheets are shift-based. This is a 24-hour day, and the day starts at midnight and ends at 11:59. Okay, so you have to get used to that. And this is in military time, so you're looking at the 1 o'clock in the morning, 2 o'clock in the morning, 3 o'clock in the morning. You probably can't see it. 4 o'clock in the morning readings. These are taken every hour, but they can be taken every 3 minutes. Readings can come off the instruments every 3 minutes, and if I go back a day, I think it's the day before, let's see, and go over a little bit. If you see one of these little chevron things, looks like a little chevron icon, and you hover over it, you'll see that there have been multiple readings taken over that hour, okay? And this can be set to literally every 3 minutes if someone's in crisis. So if you hover over that, you'll see those multiple readings, okay? I think this day also has at the bottom, just to show you while I'm on this screen, it has some laboratory tests, maybe not that day, maybe the day before. Now, there are certain things. This is the first version of this from our vendor, who is Siemens. Let me go backwards. Still don't see any. 6 a.m.? Okay, so here's some labs coming over. The group decided on 80 laboratory tests that are interfaced. So you'll see your blood gases, and you'll see a whole bunch of, you'll see 80 labs, if done, that will come over as well on the flow sheet, okay? Again, if multiple readings have been taken, we just mock this up, you'll see the little chevron. You can hover over it and see the multiple readings, okay? Now, this is organized, and I'll go back to the hemodynamics. This is organized as measurements, meaning weight, height, then vital signs and hemodynamics, and then medication drip dosage. These are the dosages of your drips, not the volume of the drips, okay? So here's your dopamine, and it gives you your gross bag and what's in the bag, and then your mics per kilo per minute, and that's your dose, and you'll see changes in doses, again, with a little chevron. If multiple things happen during that hour, if you hover over it, you'll see the trend. Now, one of the things right off the bat we saw that Siemens did not do, which was sort of a no-brainer to us, didn't understand why they didn't do it, was, if you remember, in the existing floor application, you can graphically represent all of this data. So you could graph the blood pressure over days, and they didn't put the graphing capability on the clinician flow sheet. Now, we've already been up to the corporate headquarters of Siemens and yelled at them. So very shortly in the next version, and we're going to be constantly updating this program, you'll be able to graph any of the values here like you can on the floor. So that's missing, and it's very important. And again, I don't know why they didn't do it, because it's an obvious thing to do. So that's one of the things you're going to lose, is the ability to graph when we first go up on this next week, but that'll be coming shortly. You can close any of these you want by just hitting the little arrow, okay? So if you want to get a cleaner screen, you can do that, and you can open it just by hitting it again. The next thing is the respiratory support, and these will be things coming off of the ventilator itself, okay? So if the ventilator is attached to any of the monitoring devices, these are directly put in off the ventilator settings. Next is blood gas tests, which are put underneath the ventilator. They're not down with the rest of the lab. Made sense to everybody on the group to put the blood gases right under the vent settings. Next is your intakes, which also include any tubes that have been put in, and the medication drip volume. So the intake and medication drip volume go into your total intakes. And then you have your outputs from any tube, okay? So if it's a surgical patient, and I did surgical gram rounds yesterday, if they have all their drainage tubes, chest tubes, nephrostomy tubes, whatever, then all of that data is actually available as well on the sheet. And then finally, your fluid totals and balances are next. And you'll have your 24-hour balance. And remember, this is a cumulative balance. So this is as of 1 o'clock. So that's basically your balance for the first hour of the day, right? Since the day begins at midnight. And then as you go, you start seeing the rest of your balances. And then you have your detail if you want it or not, okay? In the next iteration of this, we're just going to give you these three, your balance, your 24-hour in, your 24-hour out. The rest of the detail of where all these came from is going to be closed, and if you want to see it, you can open it up. and that was a decision made by the group that you saw. And last, as I said, is the laboratory, and then any other procedure that's being done that can be charted on a flow sheet value by the nurses, and this happens to be dialysis, okay, this example. So this is basically the flow sheet. You can, again, get this from anywhere. You can get it from your offices. You can get it from any floor. You can get it from home if you're a consult and you're called in to do something. And that is that plus the ability to take this data, put it into the upcoming data warehouse that is being developed right now and will be a 2 or 3 year project. And to do a lot of stuff with this, we can start moving this data to WebSys notes, vice versa, take WebSys notes and potentially put them into the nursing documentation. And our first go-around is going to be to put the meds that you're doing on the discharge, the brief discharge summary, put the medications into the nursing discharge summary so they don't have to reduplicate all those medications, and they're accurate and they jive. It's a JCO issue. And that'll happen hopefully at the end of March. So that's basically it. We had lots of work by the 3 women sitting down there. It's Tracy Parham and Kathy Guyette and Melissa Marsh. Kathy's our Associate Chief Nursing Officer, and Tracy's our Director of Nursing Applications for IS, and Melissa is one of our co-directors with Tracy. So they can answer any of the direct questions for nursing, and I'll take any questions you guys have or any comments, bitching and moaning, anything you want to do. Yeah, Tyler.
What's the transition going to be like on Monday? Is there going to be some overlap time when they're using paper and e-chart, or is it just straight e-chart on Monday?
It's Wednesday is the go live, and I'll let one of these women answer the question.
We flip the switch at change shift at 7, so once the nurse comes on starting the day shift, he or she will start directly going into e-chart and not using paper.
So the question was what's the change, what's the switch over? And it's at 7 o'clock Wednesday morning. The nurses will start using the electronic chart, and up until then, it'll be on paper. So for that day, the whole day, for that night, if you will, if the day begins at 12, you have to look at the paper up until 7 o'clock, and then from then on, it'll be on the computer. Other questions? I can't hear you, Rebecca. No. That's an easy answer. ED has their own little system. And any other questions or comments? Yeah, Tyler and that whole group back there, let's go to attending. How about Dave?
These numerical things that the nurses validate, can they also change the number?
Yes, they can change the number. They can actually remove it if it's ridiculous. And again, one of the surgeons asked me, is there any proof that this is safer than doing it on paper? And I said, no, there's no proof, and I don't know anybody that's done that study, and we certainly aren't going to spend the millions of dollars that it would cost to do this. I mean, our goal is to, as you know, for the last 17 years is to become paperless here, and these are the steps to do it. Tyler?
What's the downtime backup?
Okay, the downtime procedure is, first of all, if there's a code, you don't worry about the machines, okay? Do your thing, just like we've talked about with CPOE, et cetera. If there's a code, you do your thing, and then you can put in, the nurse will chart after the code of what was done. The downtime is going to be to go back to the paper record, okay? Your problem, of course, is you're not going to have any data from the day before or at the time it went down, and I have no solution for that. We do not have the money in the institution to have what's called a hot site, which would be a site like in New Jersey that has everything we have on our systems. That's millions and millions of dollars. And that, frankly, won't have if we have a network failure, that's not going to help anyway. So that's basically, unless there's any comments down here, if it goes down, you go to paper and you hopefully try to remember the data based on progress notes, et cetera, from the day before. Hopefully this thing is not going to go down very often or very long. Can't guarantee anything, but.
I can tell you this plan for how the downtime works is that the nurses will go immediately to paper to start documenting. When it comes back up, they will re-enter the data back. Even if it's been more than 2 hours, if it's subjective type data like vital signs and I know, they will go back and re-enter all the data for however long it's been down.
This is going to take, just like CPOE, this will take some time in getting used to. We will have, as we did in CPOE and large versions of WebSys we've released, we will have 24/7 IS coverage in the units for 7 days. So there'll be a whole team of IS people up there to help both the nurses and the physicians. There'll be an IS person rounding with all the teams in each unit, again for 7 days. And our hope is after 2 weeks, things will settle down and people will get used to it, which has been the trend in other things we've done. I'm sorry, JP says the rounding is 2 days with IS support for rounds, and then the entire support is 7 days, 24/7. Yes? The question is, there going to be enough computers for both physicians and nurses? And the answer is, we will find out during the first week, and if there are not, then we'll get more computers up there. We're not limited by the ability for us to get computers. We'll give you as many computers as you need. The issue is storage and space in the ICUs as to where to put them, okay? And we've kicked around the idea of tablet computers, but they walk away by themselves magically, you know. So we've settled on the computers on wheels and then computers between the rooms. If we have to do some wiring and put more of those in, we'll do that, but we'll get you enough computers.
Just as an FYI, the nurses and the nurse managers worked with the ISD director, David Brooks, is to identify how many PCs they thought they would need. And just so you all know, we did the same with pediatrics, and after their first 2 months of using eChart, they gave back PCs because it was just too many. They had the same concerns. There was going to be competition for the PCs between the physicians and the nursing staff, but they found that it wasn't quite true. So we'll provide what we all need. I just think we've got what we've got, and we need to use it before we can really determine if we need more or need less.
Jim, yeah.
Some busy times of the day, WebSys is a little low. Is our speed of our server going to be fast enough that this doesn't slow us down a lot?
All I can say is I hope, Jim. We've been working on the WebSys slowness. There are some technical problems which I'd have to kill you if I told you about. So my hope is that this is as fast as you see it here, which is our test side. And if it's not, we'll get together and try to get it as fast as we can get it. Remember, this is a vendor product, and so we're dependent on the vendor. It's very different when you have a vendor versus your own homegrown stuff, so we can move faster on WebSys issues than we can move on this. So just keep that in mind, as you know, as we've talked about. Okay, ready for some real medicine now, so some pearls.
Thank you, Bob.
You're welcome.
Yeah. Sure. I was just going to grab the lavalier.
Doesn't work.
Doesn't work. Okay.
Got to use the mic. Do you have slides?
I think the slides are.
Okay. Okay, you probably got to switch over to. I'll let you play with it.
Well, as Marshall told you, we're going to try an interesting new grand rounds approach today, a series of clinical pearls, and I think I'll let the speakers introduce their specific topics. The first speaker is Ryan Madanick, who many of you may have not met yet. I have met him for the first time today, and he's been here a year, so I felt badly about that. But he's going to talk about a new clinical entity that at least we're recognizing as new, eosinophilic esophagitis, and then Mauricio Cohen will go with an interesting perspective on coronary artery disease, and John Buse will finish up with a third presentation involving the ACCORD study and some of the new data about cardiovascular risk with aggressive diabetic therapy. So let's get started. Ryan, I'll let you go first, and Sarah's going to keep time on these guys.
Thank you. For those of you who don't know me, I'm Ryan Madanick. You may have seen my name on reports or consults or something to that effect. I'm from the University of Miami. I was recruited by Dr. Shaheen. Oh, wait, yeah, by the way, yeah, we did beat Duke last night. I'm still a Hurricane at heart, and I bleed orange and green. Anyway, this is an exciting topic that many of you probably never heard about in residency, and for those of you who are residents, hopefully you'll learn a little bit about this as you're going through our rotation. Wow. Anyway, thank you very much. It was a pleasure. That was interesting. Maybe I should just advance it this way.
I'm going to put this down a little.
Yeah. Okay. So this is actually the very first case of this that I saw when I got here. I'm in the esophageal center. I work with Dr. Shaheen very closely. So for any complex esophageal issues, just don't hesitate to give me a ring. Anyway, this is a 20-year-old white man who had recurrent dysphagia. It was ongoing since childhood, but he really ignored it, but impacted food. Sometimes took hours to pass, and he occasionally, frankly, got obstructed and couldn't swallow his secretions. Whenever he would go to the ER, though, everything had already passed, and he'd just kind of go home. Every once in a while, he had some heartburn and chest pain. When we did endoscopy on him, he was actually referred from the outside because of a dysplastic inflammatory nodule. But when we did endoscopy and got this history, what we found was multiple subtle rings with linear furrowing, which is sort of a train track appearance. And we dilated him with a balloon up to 12 millimeters. And for those of you who don't know, a normal esophagus diameter somewhere between 25 and 30 millimeters. This 20-year-old man had resistance at the dilator at about 12 millimeters. And we biopsied, and he had moderate eosinophilic infiltration up to 30 per high-powered field. So we made the diagnosis of eosinophilic esophagitis on him, and we've started him on treatment. This is about a year ago. He's doing great as of now. But one of the things that's very interesting is this slide. What you'll see is over the last decade, there has been an explosion of case reports and case series and subsequent some good data publications about this trend. In the mid-90s, there was virtually nothing. This was basically pediatric literature that they first recognized it. And then in about the early 2000s, and starting about 2002 was kind of when this all trended up, we see a drastic increase. And last year alone, in the year 2007, I just updated this slide, there were 81 publications. And that's a massive increase, and we're seeing a lot more interest in the research of this condition. So what I'm going to show you now is all case-based series or case-based data, so there's very little true science behind this. One of the main thoughts of pathogenesis is allergic esophagitis. So if you hear people say it's an allergic esophagitis, this, in the majority of patients who have real eosinophilic esophagitis, probably have some allergic component, whether that's true food allergy, or one other thing that could be happening is that it's a swallowed aeroallergen. In other words, there is something in the environment that is aerosolized, and then when they swallow it, it affects their esophagus. We might actually be seeing more of it in the proximal esophagus, which goes along with that theory, versus a reflux esophagitis, where more of it is located in the distal esophagus. So how is this presenting? The most common presentation is dysphagia and food impaction. And a lot of times people won't even complain about the dysphagia. Just like this gentleman that came to our clinic, he was referred from the outside. He had had dysphagia for years. He thought it was normal to have food get stuck. It's probably the number one cause of food impactions nowadays. And if you have patients where even 3 or 4 years ago they had a food impaction or they had dysphagia that wasn't subsequently evaluated, go back and look. They may actually have this condition and never have been biopsied, because up until about 2 years ago, we didn't routinely biopsy. So this is what we might see on endoscopy. What you'll see here are multiple rings in the esophagus. Almost looks like a trachea for those of you who do bronchoscopy, except you don't see that posterior wall. It almost looks like a trachea. They used to call this a feline esophagus. This is a classic board question. This one may very well be for the residents on the boards in a couple years. These little white papules and subtle rings with some furrowing, and you can see what happens. Even if you just go down and endoscope them, you may get a large tear because the mucosa is so very thin. So we have to be very careful when we actually go ahead and endoscope and dilate these patients. What you should see on histology is an eosinophilic infiltration that goes throughout the mucosa. And on high power view, what you can actually see somewhere around here are these microscopic eosinophilic abscesses. If you go back in your textbooks and look about old GERD diagnosis, this is what it was. So we now have to revisit our GERD histopathology. And nowadays, if you look at any biopsy from the esophagus over the last year or two, they will almost always give you a number of eosinophils if there is a significant eosinophilic infiltration. They used to not. They would just say mild, moderate, or severe. We still don't know the best way to manage this, unfortunately. Currently, probably the two or three top things we do are allergy testing with an elimination diet, food-type elimination diet. And the other one that I do almost exclusively is swallowed aerosolized fluticasone. So they take Flovent, they shake it up. Instead of breathing it into their lungs, they take a deep breath in, puff it, swallow it, and then breathe. And they do that 4 times twice a day for 6 weeks. And we think that should hopefully bring down the inflammation to the point where it's going to stop laying down fibrosis so they don't get a very thin esophagus. I say this judicious dilation because these patients are very well known to perforate when you do endoscopy or when you dilate them. So in summary, this is only a 5-10 minute pearl. There is emerging information about all aspects of this condition, and you really should know about it if you have patients with refractory dysphagia, refractory heartburn, or refractory chest pain. The GERD association is probably quite minimal, but there may be some overlap. So if there's any question, we'd be happy to help you with that. To make the diagnosis, we need both the clinical picture, the endoscopic picture, and then we need the histologic findings. We're going to aggressively look for it, but very judiciously dilate it. Right now, medical treatment seems promising, but we have a lot more research to do on it. Thank you very much for having me, and I'll take some questions.
How about eosinophilia? Does it correlate at all?
You mean peripheral eosinophilia? No, not at all. And if you do find it, then you have to look for hypereosinophilic syndromes. Yeah, Dr. Yankaskis. No questions? Oh, we're not allowed to take questions. Can I take Dr. Yankaskis? Yeah.
Thank you. Some asthma is associated with eosinophils and other asthma with neutrophils. Is there a neutrophil equivalent?
Not that we know of as of yet. No, because in general, esophagitis has generally always been associated with eosinophilia. So not that we're aware of as of yet. So, okay. Well, thank you very much.
Where's the pointer? Is this pointer? Yes. Okay. Yep. Thanks for having me. I'm going to show a case of courageous CAD management, and you will understand why I'm using the word courageous in a little bit. So a few findings influenced my clinical judgment last year. The first one was writing a book on goals of therapy in patients with refractory angina that changed my way of looking at patients. I mean, you know, I have a very aggressive way of treating patients from an interventional standpoint. So up to that point, I thought that everything was cured by a stent. Then I attended the American College of Cardiology in March of 2007, and was there at the presentation of the Courage trial that compared optimal medical therapy versus optimal medical therapy and PCI in patients with chronic stable angina. This study was highly featured in the media. And then, before then, in 2006, there were the results of some meta-analysis comparing bare metal stents versus drug-eluting stents that actually gave a lot of ad press to interventional cardiology as a whole. And finally, I was very influenced by an interview published in the News and Observer. So this is a book chapter. These are the main messages of the book chapter. There's a meta-analysis of 11 trials comparing PCI versus medical therapy in patients who are stable with chronic CAD. And there was no survival benefit for PCI, and medical therapies, including diabetes management, cholesterol reduction, control of hypertension, and obesity and lifestyle modification were highly recommended. The ARTS randomized trial that compared PCI versus CABG in patients with chronic CAD showed that only 19% of PCI patients and 38% of CABG patients were free of angina and anti-anginal therapy at 1 year. So I thought that was pretty low. Then these patients with chronic CAD in general have a low mortality rate. The Iona trial was a study looking at nicorandil in this population of patients and found out that at 1.6 years of follow-up, the survival was, the death rates were about 4.3 to 5%. And then we also have data now on aggressive statin therapy that shows that statins can actually reverse cholesterol plaques according to intravascular ultrasound studies. These are studies that come from the Cleveland Clinic by Steve Neeson. So those were the highlights of the book chapter that I wrote. Then this is the Courage trial, as I mentioned before. I'm sorry for the small fonts. This is as presented at the ACC. You can see that they did not present the upper part of the randomization tree. They just presented the patients that were eligible for the study, and then they enrolled 74% of the protocol eligible patients. These are the results of the study. The mean follow-up was at 4.6 years. These are the results for optimal medical therapy. They looked at the measure at the primary endpoint of survival free of death and or myocardial infarction. And these are the results for PCI plus optimal medical therapy. You see a little attrition rate here initially, probably due to the increased events associated with upfront with the procedure. And then the two curves come together, and there's actually no statistical difference at the end of follow-up. Then these are the meta-analyses that were published, lots of press, and the major question was whether or not drug-eluting stents increase death. There were two meta-analyses that were mostly not patient-derived data, but derived from the publications that showed an increase in death and MIs in patients treated with ES, mostly with a worrisome stent thrombosis. Then we had when I came back from the ACC, I saw this illuminating paper in the newspaper. We have here Dr. Hadler. He's a professor here who is a critic of medical interventions that are not clearly backed by the evidence. He calls my specialty one of the biggest scams in U.S. medicine. So I was deeply affected by that, and it's an industry that has grown despite the total lack of evidence that it's good for me, the patient, said Hadler, who is an attending rheumatologist. So the following day, I go to clinic, and then I get the patient. So as you can see, the date of the interview was March 27th. Then I go to clinic the following day, and then I have the 62-year-old Caucasian male that is seen with chronic stable angina, completely untreated. He adamantly denies any type of rest angina or any change in the nature of symptoms. The LDL was 154, so I decided to go ahead and treat him medically. No interventions, just do a stress test, and this is a summary of the stress test. He went on the treadmill for 9 minutes, reached 10 meds, which is a pretty good effort. I put him on atorvastatin 80 milligrams, so I truly did optimal medical therapy. I also referred him for cardiac rehab, because that's a new program that we have now in Salar City. I saw him in July, and he was doing exactly the same as he was doing back in March when I saw him for the first time. I was stubborn, and I said, I'm going to just continue to be courageous. So looking back now and using the data from the Duke treadmill score, which is a formula to calculate the risk according to a treadmill test, I found out that the risk actually for this gentleman was moderate, with a 1.25% annual mortality rate. The guidelines recommend that these patients should have either cardiac cath or an exercise imaging study, but these guidelines were from 1999. Way back before the Courage trial was published. And then the patient had limited resources and did not want to go for any subsequent study. So I said, well, it's a low-risk condition, so let's continue medical therapy. He comes back in January, and then he feels the chest pressure after walking 150 yards. He's still frustrated because the symptoms have not really subsided, and now the LDL came from 154 to 84, which is which is very close to the optimal level. He was on good medical therapy, he had gone to exercise, so I decided let's go ahead and do a cardiac cath. So this is a cardiac cath, and you can see here there's a 95% left main stenosis, there's a 95% proximal LAD disease. This is another view. Of course, the patient went for bypass the following day. So I think I learned some lessons here. We know that the data shows that there's a significant mortality reduction for patients with left main disease from a meta-analysis, 68% at 10 years. The higher the severity of the disease, the higher the benefit with revascularization. So I think we still have to treat these patients aggressively. We have to look very carefully at the clinical trial. So this is a part that was not presented at the ACC. And you can see that 35,000 plus patients were screened and only 2,200 were randomized. So that represents 6.4% of the total population. So, it's a population that is not representative of all the patients we see in our clinical practice. And then also we have to be careful when we extrapolate. All patients were enrolled after angiography. Here I did not do angiography, so don't treat blindly. We did randomize everyone after seeing the anatomy, so there's clearly an investigator bias because probably the lower risk patients are the ones who are going to be enrolled. Actually, 80% had minimal or no angina. Flood hypothesis, we knew before the study was done, the PCI did not decrease mortality. The projected composite 3-year event rate was 21% in medical therapy and 16% in the PCI group. That was what they used to calculate they used to calculate the sample size, and then they had to change some of the inclusion-exclusion criteria so they could have more events during the study. There was an unfair MI definition for the PCI group because they just adjudicated according to NECK and B increased. That, of course, increased the number of events in the PCI group. And there was a low use of new technologies, low use of DES, which is drug-eluting stents, only 2.7%. It's true that the study was done before the inception of drug-eluting stents. 70% of the patients had more or equal than 2-vessel disease, but only 41% received more than 1 stent. So it's clearly that these patients were not completely revascularized, and incomplete revascularization is associated with worse outcomes. So I'm going to stop here and thank you for.
Thank you. How many of you heard about the Accord trial in the last 3 weeks? Most of you, I guess the rest of you must live under a rock someplace because it was literally in every newspaper and every television show. I think it even made it on Entertainment Tonight. So if you look at the Accord trial protocol, which I recommend that you don't, but it's available on the web at www.accordtrial.org, the rationale for doing the Accord trial was that there had been a number of studies that were moderate in length, up to actually 12 and a half years, that in the intensive group got to an A1C of about 7%, and in the standard group, A1Cs above that, generally around 8%, some of them a bit higher. And then we're able to follow patients for cardiovascular risk. Most of them, but not all of them, suggested trends towards reductions in cardiovascular endpoints. In particular, this VA cooperative study for diabetes, which was only 157 patients, actually showed a 40% increase in cardiovascular events at 2.5 years. So there's been this idea that diabetes management may improve cardiovascular outcomes, but it's been unproven. Diabetes management has been shown to reduce microvascular complications, the eye, kidney, and nerve disease in diabetes. So the Accord trial was designed, it involved 10,251 subjects. They had to have an A1C of greater than 7.5%. I don't have the numbers, it's published, regarding how many people had to be screened to get these 10,000 patients, but the number one reason for exclusion from the trial was that the A1C was too low. And it was about 5 patients screened for every patient randomized. They were randomized to a treatment target, an A1C less than 6%, versus an A1C between 7.0 and 7.9%. And the major difference between the two arms was how much of the same stuff did people get. So in both arms of the trial, most patients were on metformin. A lot of them were on TZDs. Many were on insulin, but there were more patients on TZDs and more patients on insulin and more patients on higher doses of both. And lots of patients here were on 3 and 4 oral drug therapies plus 3 or 4 injections a day of insulin. There are 2 sub-studies, a lipid sub-study looking at the combination of statins with fenofibrate in a blinded fashion, and a blood pressure sub-study looking at blood pressure target of less than 120 versus less than 140. But what's happened, the announcement that came in the press, is that all the intensive patients in the Accord trial are being switched to the standard arm. Now, why would they do that? Well, after 4 years of follow-up, the DSMB rang up NHLBI and said, hey guys, we've been looking at this. There's an increase in mortality in the intensive group. So there are 257 deaths in the intensive group, 203 in the standard group. That translates into a difference of 3 deaths per 1,000 patients per year. So a relatively small increase, but in a very important endpoint. So the study was stopped based on an excess of 54 deaths, and the only thing that's been released publicly so far is they've done a pretty careful search to see whether it's a particular drug. That's mostly on the basis of all this brouhaha about rosiglitazone over the last year, and they said basically no drug or combination of drugs seems to be statistically responsible for this issue, and they've also looked very carefully at hypoglycemia, because going into the study we knew that if you took elderly patients, most of who'd had MIs or had multiple risk factors, and you flogged them really hard, like literally if 49% of their blood sugars were less than 70 and their A1C was 6.1%, we were supposed to increase their insulin dose. If 50% of their glucoses were less than 70, we didn't have to. So this is a very intensive protocol, but as best they can tell, it's not the hypoglycemia. Now, I have to tell you, if you're looking for 54 events in 40,000 patient years of follow-up, there's not a lot of statistical power to slice and dice this thing in a lot of different ways and look for trouble. So what does this mean for diabetes management in America today? Well, there are 3 other trials that are directly addressing the issue of intensive glucose management as a technique to reduce cardiovascular disease. Advance, which has announced that they have an A1C of 6.4 in their intensive group and an A1C of 7% in their standard group. Their intensive program is much, 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 much less intense than the Accord program. Their intensive program basically was start a patient on a sulfonylurea and send them to their doctor and let them intensify the therapy how they want to. These patients were relatively early. Over half the patients had an A1C under 7.5% at enrollment. The VA diabetes trial is done at the VA, which has some of the most grizzled diabetes cases in America. I mean, these people got flogged really, really hard. But the rumor is that this group has an A1C of 6.9%, and this group has an A1C of about 8.5%. They treated these patients very intensively. Whether they did it as intensively as ACCORD is unclear. The other announcement that came out is that Advance has said that they don't have an increase in mortality. But again, the difference here may be that they didn't have to flog these patients as hard to get to an A1C of 6.4% as in ACCORD. And then the trial that I think will give us the best information about what are the consequences of getting an A1C down to 6% is the Origin trial. So these are all the trials that are ongoing looking at different techniques of glucose lowering. But in Origin, the technique is insulin versus standard care. So they definitely will end up with a difference in A1C, but because they're starting in patients with either pre-diabetes or new onset diabetes on a single oral agent, they're likely to get to an A1C under 6% in the Origin trial, and we'll have that result next year. So there's a lot more information to come. I think for now, what we can say is that a very intensive program of diabetes management, which, you know, in some ways bordered on insane, was associated with a small increase in mortality. The thing that didn't generally make it into the press is that if you look at 62-year-old patients, half of whom have prior coronary disease and half of them have 2 risk factors beyond diabetes, you would expect about 3% annual mortality, and even in some series 5% annual mortality. But in ACCORD, overall, it was about 1.2%. So the ACCORD patients in general did very, very well, though there were 50 excess deaths in the other group. So having thought about this a lot, the language in the American Diabetes Association guidelines, I think, is still appropriate, and that is that lowering A1C to an average of about 7% has clearly been shown to reduce microvascular and neuropathic complications of diabetes and possibly macrovascular disease. Therefore, the A1C goal for non-pregnant adults in general is less than 7%. Epidemiologic studies have suggested an incremental, albeit in absolute terms, a small benefit to lowering A1C from 7% in the normal range. And that is really key. When you start pounding on people to get their A1C from 7% to 6%, the payoff, as best as we know it, is really small. And the consequences, both with regards to complexity of care and expense, can be substantial. But in selected individuals, if you were to get to an A1C of less than 6, that might be okay. And then most importantly, less stringent A1C goals may be appropriate for patients with a history of severe hypoglycemia, patients with limited life expectancies, children, individuals with comorbid conditions, and those with longstanding diabetes or a minimal or stable microvascular complications. Now, you guys probably never read the American Diabetes Association guidelines, but when you think about this, this is like, you know, about 85% of patients with diabetes in America. And I do think the ACCORD study does suggest that we need to be judicious, particularly in older patients with pre-existing coronary disease, in flogging them really hard to get their A1C under 7. I don't have a problem with using 1 or 2 oral agents and bedtime insulin and to get their A1C under 7. But if their A1C is 7.2, I might not, you know, hit them with another oral agent or add 4 more injections of insulin or whatever else that you might try, at least until we get the results from these other trials, which we should have in June of this year, in September of this year, and then again in June of next year. So this answer, I think, is going to be very well elucidated over the next year. Thank you very much.